Good morning or good afternoon for some of you out there. My name is Katie Phillips, and I want to welcome everyone to this presentation by Dr. Frank Buono on pain management. Dr. Buono is an associate research scientist in the psychiatry department at the Yale School of Medicine. His research has focused on incorporating technology into pain management strategies, particularly for NF patients, and we're very excited to have him here with us today to share his research. Dr. Buono will try to answer all of your questions, so please leave them in the Q&A box at the bottom of your screen, and we'll do our best to get all of your questions answered in the next hour. And now I will turn it over to you, Dr. Buono.
Thank you, Kami, for that wonderful introduction. I appreciate this, and I appreciate the opportunity for the NF Central Plains to allow me to talk about something which I'm so impassioned about. Yeah, as Kami said, if you guys have questions, I'm kind of an open-ended book. If you have questions for me at any point in time, just feel free to put them in the Q&A. I will try to address them at that time. If you feel like you want to wait and answer them later, I can do that as well. I'm gonna try to go over everything I can within the hour. But I know there's a lot of material specifically with pain and how pain affects neurofibromatosis, so I'm going to do my best. If I run over, I'm more than happy to share my slides with NF Central Plains, and so they can see it and you guys can get access to that. Just to give you a quick little overview, Kami did a great job at introducing me. I am an associate research scientist in the Department of Psychiatry. I do a lot of research within chronic pain and chronic pain management, but I also want to give you a little shared background. I was diagnosed with Neurofibromatosis Type 2 at the age of 9 and have been living with this for about 30 years. Along with my sister, we were both diagnosed about the same time. She and I have had multiple number of procedures, and as most individuals who are probably watching or listening to this right now, surgeries are pretty prevalent within the NF population. So much so that the last procedure I had, I was actually paralyzed from the hips down due to a post-operative infection where they were removing 3 tumors from my spine. While they removed the tumors successfully, that post-op infection unfortunately left me paralyzed, and after 7 months of grueling physical occupational therapy, I was able to walk and ambulate. I still have a little bit of a deficit when walking. I have to hold on a railing or whatnot, but I can still chase after my 2.5-year-old to a certain degree. But this is important because I also suffer from chronic pain, and there are tips and strategies that I utilize every day so that my chronic pain and I can manage my chronic pain. And so I want to share both my clinical expertise along with my personal expertise to you so that you guys can help yourselves or help your loved ones. So at the end of the presentation, my goals are to help you understand what pain is, how pain affects neurofibromatosis. I've been doing a lot of my research is with NF1. I have some preliminary research with NF2, and my lab and I are just starting research on Schwannomatosis. We are going to be talking about complementary treatments, sometimes also known as complementary and alternative treatments. So those can be sometimes interchanged, but we typically call them complementary treatments. And then I'm going to also talk about chronic pain in the workplace. And then I'm going to have a little bit of open discussion with pain and hopefully answer your questions and if they are there. So I think the place we need to start is providing a really good definition of what pain is. Hopefully you can see this screen pretty well, but and you look at the year when this was actually, this specific definition came out was 1979. And because the International Association of Study of Pain has come out with a definition of pain for the last 40 years. What this was the most seminal definition, and what is currently utilized in most pain textbooks, pain manuals, and whatnot. Excuse me. So the definition: pain is an unpleasant sensory and emotional experience associated with the actual or threatened tissue damage or described in terms of such damage. It's a very complex definition. So you think of sensory as, your hearing, your smell, your touch, right? And then there's this emotional component, right? Which is, happy, sad, anger. All of these components can actually be impacted by some issue of tissue damage or sensory misfire, which can inflict pain. We're going to go into a lot more definition of this, but I just wanted to give you that basic understanding. And so that you can understand this, chronic pain is a large disease within the United States. Currently affects about 100 million people. And if you think about that, we have 375 million people in the United States. So that 1 in 5 are dealing with chronic pain is really close to 1 in 4 now. The Relieving Pain in America that you see, this blueprint, came out last year from the Institute of Medicine, and it's considered the Blue Book, and it is a chock full of information. You can find this if you just Googled Institute of Medicine Relieving Pain in America. There's a lot of information that can be useful for both academics and for parents and for consumers. Costs within the society, just to give you a relative component, you see 500 to 635 billion with a B per year. And what you'll see, and probably what you've heard, is that the typical treatment for pain is with opioids, and we have that opioid epidemic because of this. And I'm not going to go into too much of that, but I want you to understand that opioids are one way of helping, but it's not a long-term solution. It is pretty much everybody who is on this call would be able to, say that they've seen this at one point in time. This 0 to 10, pain severity scale. This pain severity scale is unilaterally done for adolescents, for pediatrics, and for adults. But this is only one aspect of pain. And I think you need to understand that, and so when a doctor asks you, your pain is a 7, okay, well, what's that relative to? Is that relative to yesterday where I only had a 5, but I did a lot more strenuous activity? So this is something which we need to correct in the pain community and from our patient providers. So I'll talk more about this in a little bit later, but I wanted you just to understand that this is only one factor of pain. Excuse me. And I don't want to give you the entire textbook of pain, but I think that you need to understand so that you can advocate for yourselves all the understanding of what chronic pain or what pain is. You have to, and in that, there are different types of pain. There's acute pain, there's recurrent pain, and there's chronic pain. You're going to hear me talk about chronic pain a lot because within the field of neurofibromatosis and what I have done and what others have done, you typically don't see acute pain a lot. Acute pain, is brief, it's transitory, and in essence, it's so. To give an example, an individual plays basketball and they twist their knee in trying to dribble the ball. That's something which would be considered acute pain because it's going to hurt for a week or 2, or maybe even 3. You'd be icing it in ibuprofen or some sort, and then it should get back to, you should be back to 100% within a month or two. Chronic pain is something that is longer lasting. It is defined crudely, but as any pain that lasts for longer than 3 months. So we're talking post-surgical pain. We're talking something which was fractured or hurt or herniated, if you will. This could last for 3 months or longer. And so you need to understand, when I talk about chronic pain, I'm talking about pain that's lasting for longer than 3 months. And most of my research and most of the research that is done with neurofibromatosis is specifically talking about chronic pain, because acute pain, as I said, is not really dealt with within the NF population. And so with that, there are ways to describe pain. And I promise that I'm going to get into a bunch of other information here, and specifically within NF, but I just in a moment, but I wanted to provide just a couple more slides with understanding pain, that these variables, these descriptors, are just some of the types of pain. And I would ask you to even think about your own pain or pain of a loved one, and see if any of these pain descriptors are appropriate for your or their pain. And if there's something else, we could, you definitely need to think about that, and how does it feel? Because these pain, is going to provide information to your medical care team to say, okay, well, if it's throbbing, it's going to be a different type of treatment than if it's just aching. And so you have to understand those definitions, and we'd have to go into a much longer conversation about these descriptors, and we could do an entire hour, or at least I could talk about an entire hour of this as well. And then I think that you also understand that there are multiple different dimensions of pain. And I think this is where I was talking about, if you looked at that slide from a couple seconds ago, I'm gonna go back right here. If you saw this is a pain severity scale. So what I'm talking about right now, there are multiple dimensions of pain. There's severity. So you can see, look at how severe that pain is, how intense that is. The interference, well, how much does it impede your daily routine? Tolerance is something which is not defined, not well measured in the pain community, and within NF, it's very hardly even touched. Talking about how much an individual can tolerate, because, as I said, what I can tolerate might be completely different for you. And so that tolerance factors into your severity, which factors into your interference. And then the catastrophizing, which goes into the emotional component of this, which is that negative emotion and the response to the pain. So how does that affect that severity or your interference or your tolerance? And so you can see how these are all interwound, interconnected. And then lastly, this is a threshold. And I think for threshold, you have to understand that this is the minimum amount of stimulation that would evoke a response. So in other words, if I hit my foot against the door, that's going to cause me to say, ouch. But, how much does the pain in my back evoke that stimulation for me to have to get up and to do a yoga exercise? So that is something you have to keep in mind. So I'm going to show you that, not only do we have other issues, there is the cognitive distortions in the physical, which we talked about, but you also have to understand that this one is the most important that I want to just briefly touch on, which I haven't touched about, is secondary physical problems. So, and this is something which you need to be mindful of as well, which is, because you're in pain, your back hurts, your knee hurts. Let's just take your knee, for example. Because your right knee hurts, you're going to be putting more effort on your left knee. And because you're putting more effort on your left knee, you might have more secondary issues with that left knee, i.e. arthritis or tenderness or whatnot. And so you have to be understanding that, chronic pain is not just, one side of your body, it's the entire body plus your brain. So I think we've covered a lot of this, previously, but I just wanted you to understand how persistent pain can be a factor of all of this. When it comes to treatment of pain, there are 4 different typical processes. And I am not a medical doctor by trade, but I can talk very briefly and very just brief overview of this. And so you have to understand that there are different modalities. There's psychobehavioral. So this is my area of expertise. So we're talking cognitive behavioral meditation, we're talking treatment. So we're talking, acceptance commitment therapy, we're talking dialectical behavioral therapy, and utilization of some psychoanalysis or whatnot. There are procedural, which then you get into the medical procedures, which are nerve blocks, steroid injections, pumps, acupuncture. There are physical, which is, what, my wife does, which is, occupational therapy and physical therapy, which is movement therapy, modalities, orthotics. And then there are medicines, which are, your typical doctor, where you're going to talk about opioids and antidepressants and anticonvulsants. And so there is this split between self-care and clinical care. And so we have to understand that each of these can help, but the end goal is what's highlighted in circles, is to reduce the pain, restore the function, improve your quality of life, and cultivate a well-being. And that's what needs to be talked about, which more than anything else when you're having chronic pain. How we can reduce your pain, with minimum usage of opioids if possible, restore your function to, to get into back, not necessarily where you were originally at, but to at least a way where you can actually functionally be able to carry on. Improve your quality of life, because we know that if we improve your quality of life, your depression goes down, your anxiety goes down, your thoughts of self-improvement go up, and then you cultivate a well-being because of these variables, and that is really important. So I think that you all have to understand that this is something which we want to improve within the field of NF. And so my little guy here who hit his thumb with the hammer, I'm not talking about, when we're talking about pain with NF, I'm not talking about pain, someone hitting their thumb. I'm talking about, or someone doing their crunches. I should get better at that, but it's not the abdominal workout. I'm talking about, your cafe au lait spots, or your dermal neurofibromas, or other tumors that can cause you pain. And I want to present to you 2 cases of pain that I deal with, which I've been consulting with and helping these clients for a couple of years now. And they've graciously allowed me to use their examples for you so that you can understand what they're going through and maybe help you guys in turn. So we have Ellie and we have Mark. Their names have been changed to respect their privacy. So Ellie is 18 years old. She was diagnosed with NF2 when she was 5. She's had 31 whopping surgeries in the last 10 years. It's crazy. She has a facial drop to her last surgeries, and she's deaf in 1 ear, which is all pretty typical for an individual with neurofibromatosis, and she's dealing with chronic pain. The funny thing is, when she goes to her medical doctor, they're looking more at the tumors, and which I understand, but they're not talking at all about chronic pain. And she's extremely frustrated with her, her care, because they don't talk about her pain, which is more impactful right now than anything else for her. And in Mark, it's a clear case of pain. He's 31 years old. He has NF. He was diagnosed at 24, so a little bit later in life. He's currently taking Vicodin and Percocet for pain reduction, which is both of them are very powerful opioids, which are have some lasting effect. He's unemployed, uninsured, and he has a visual analog pain scale. So that 0 to 10 scale with the happy and smiley faces that I was talking about, daily living with an 8. And that's even with the Vicodin and Percocet. And so when talking to him and working with him, we are using a lot of other types of treatment where we've introduced yoga to his routine. We've introduced other complementary approaches to help him reduce his pain symptoms. And while they have been somewhat effective in reducing his score from an 8 to a 6, there isn't still a lasting or a true understanding of how we can get his from 8 to a 1. And so we keep on pushing with him and with Ellie to how we can help them get their pain scores down as much as possible. I also should make a note, to get Mark's pain from an 8 to a 6, that is pretty phenomenal. And so we're trying to do as much as we can to help out with each case. And I think that you have to understand that to get a score from an 8 to a 6 is a very big change for you, and you will see a change in your experience. Research-wise, if you put in a systematic review, and I think I have an article that I'm currently being evaluated for publication. If you put in pain and neurofibromatosis, there's only 41 articles that have met the criteria of our search. Compare that to other diseases like, and I'm going to jump to the bottom, where you have sickle cell or cystic fibrosis, which have the same prevalence, if not more, within as in neurofibromatosis type 1. You have thousands of articles about pain. So, the field of neurofibromatosis from a research standpoint is also very much behind in understanding chronic pain and the effect of this as well. So it's not just, from a clinical standpoint behind, we're also behind in a research standpoint. So I want to present a little bit of data that I have. I'm more than happy to provide more information as we get to it. I know I'm a little bit behind in my slides, but I'm going to try to get through this as quickly as I can. So one of the measures that we looked at, when we were looking at, and this is specifically with NF1, and looking at your severity of pain, we're seeing that individuals with NF1, and in our survey, which was published in 2019, I believe, we noted that an aggregate pain severity for individuals with NF1 was 4.7. That, you think, well, that's pretty moderate of pain, right? Well, considering that if we looked at individuals with a glioblastoma or more severe cancers, their scores, if we look at the exact same measure, are 3s and 4s. So we're noting that these individuals with NF are having a lot more pain. Also, similarly, they're affecting our life more. So I want to just highlight one variable. Your sleep is being highlighted more so, almost to a 6. There, enjoyment of life. The ability to just work. Is also. And then, you guys as individuals who are suffering from the disease, within neurofibromatosis, you understand that, this pain can come from a multitude of different areas. And similarly, this for NF2 and schwannomatosis, pain can come from different ways. It can come from the spinal cord tumors, like what I'm having for NF2, and then chronic pain for Schwannomatosis. So all of this can evoke certain different types of pain. And I should say chronic pain. So when we go to talk to treatments of pain, there are 3 main treatments right now available for individuals with neurofibromatosis. And I'm speaking broadly across all 3 different types. So it's surgery, radiation, and medication. And with this, so I like to point out the negative, that you understand this. Obviously it's going to be invasive. Someone is cutting you open. It's going to cost, if you have a good insurance, it might not cost you as much as if you don't have a very good insurance plan. And it might not help with the pain. Just because a tumor is removed, Dr. Gutman, who I believe was involved in this at some point, pointed out in his article in 2015 that just because you remove a tumor doesn't mean that the pain goes away. Radiation, this might work for individuals with neurofibromatosis type 2, but it's invasive once again because you're putting screws in, and it's a problem. There is a cost to it, and it might not help with the pain, and it's not all appropriate for NF1 typically. Medication, you see a common theme coming here. It's side effects of the medication. You can feel lethargic, you can feel more depressed, and you can feel not willing to want to do a lot of work. It also can be very costly, even though the pharmaceutical companies will try to get a pain medication to you as cheap as possible. It's still going to cost money, and then it might not help the pain. So just to provide more information to you, and this is something that you might not know, but there is a number of individuals who are exposed to a lot of surgical procedures. And we showed this, the average number of surgeries for an individual with neurofibromatosis throughout their lifetime is almost 5 procedures with a standard deviation of 5, meaning, you can have, in this range, there's been individuals which only had 1 procedure, but there's individuals who had 31 surgeries. And so there's a lot of variability within NF. And then with the type of medications, I want to look, you see fentanyl. Fentanyl is probably one of the strongest drugs on the market today. It's 3 times stronger than morphine. And it's being provided to individuals with neurofibromatosis. So you have to be very mindful of what you're being provided. And then if you look at the bottom, multiple drugs. So individuals were prescribed, not kind of in place with what Mark was given. He was given 2 different drugs to treat his chronic pain. And, 2 different types of opioids. And these are all different opioids. I should have mentioned that earlier. And it should be taken very carefully. And so on the bottom, I mentioned that at least 17% of these individuals are currently taking medication when we published our findings. That's a large percentage. The average individual with opioid medication right now, and the national average is 10. So there's more individuals with neurofibromatosis who are taking medication than the national audience. So with this, I want to focus a large point of time to complementary treatments. I focus a lot about complementary treatments in addition to psychosocial modalities, because there is still a lot of empirically based evidence for many of these different techniques and approaches, and I want to just focus on this. So when you think of alternative treatments, you think of a massage or acupuncture, if you will, or even someone who's very, very bendy doing a yoga pose. And I would, if I did that, I'd probably break my leg in 6 different places. But you know, those are the typical procedures. But there are others out there which have a lot of evidence base to them. And just to let you guys know, the National Institute of Health in 2016 reported that 30% of the adults were using, and 12% of adults were using other approaches than Western medicine. Western medicine means, you know, medication or surgery to help report, to reduce their pain symptoms. Within 2015, there was $30.2 billion spent on complementary ill treatments. And then if you guys are bored on a Saturday night or Sunday morning, look up the ICER report. It's the Institute of Clinical and Economic Review. This shows clearly that a conjoint effort of using complementary alternative treatment approaches are more effective and have better for reducing potential harm and greater benefit than standard medical treatment. Now, I'm not saying by any means you should reduce your chronic, you drop all your medication. I would never say that, but I just look at the reports and see what the information that's out there. So with that, you also have to have the 10 most common complementary treatments since 2012. So natural products, you have to be very mindful about that. And you know, I'm not going to get into a conversation too much about like fish oil or shark cartilage or cardamom because there's not a lot of research talking about that. But if you look at yoga and deep breathing and meditation and homeopathic components and guided imagery, there's a lot of empirically based evidence with this. So much so that I'm going to show you a next slide. Everything which is starred has been shown within the NF community to be effective to reducing some chronic pain of some sort. So massage, acupuncture, physical exercise, stretching, counseling or therapy, yoga, physical therapy, meditation, mindfulness exercises, occupational therapy. I have those that have not been, which I have not talked about, like i.e. medical marijuana or acupressure or supplemental vitamins. It's not saying that they're not effective. It's just saying that we don't have the research out there to clinically show that they are empirically validated, which means we need to do more research on that. So what we did in my previous study is we evaluated, you know, how many people are actually trying or have tried. And so we looked at evidence-based approaches. Only 9% of individuals in our sample of 250 individuals have tried yoga or doing yoga in the last 30 days. Only 25% have tried it in their lifetime. And by lifetime, meaning one time, at least one time, which means there's not been a lot of individuals who have actually tried yoga. And these numbers are relatively low across a lifetime, except with the exception of physical exercise. And so we have to be more understanding that there are other different approaches for reducing of chronic pain than simply a medication or a surgery. And then if you look at other treatments which are not empirically validated, we have some fluctuation. So you know, there are some individuals who have utilized other approaches, which you know have been are currently being utilized, but at the same time, you know, have not been shown to be clinically effective. So there is some differentiation between those that are empirically validated. And by empirically validated, I really mean, you know, science-tested, evidence-based information, you know, through some type of randomized control design approach. And I can more than happy talk offline or talk to individuals about this if you have any questions. So one of the variables that I want to just jump to really quickly, and I hope it's 1:30 my time, so I think I have a couple more minutes. But chronic pain in the workplace, and we've got some very interesting data that we are just about to publish in our lab about chronic pain and how it affects your work. And I apologize for the animation. My research assistant did that for me, and I'm not the most technical savvy individual. But we know that quality of life affects NF1 and NF2 as well. And we know that specifically, and we're looking at, I'm going to jump down to here, just up to the bottom, that prolonged job security, specifically how someone's feeling about their own employment can be negatively associated with their well-being. And this has been well published and well shown. So what we did is we did a work readiness scale, and we showed if we looked at individuals with neurofibromatosis and we looked at individuals who were not have NF, but they both have pain, that individuals with NF are significantly more worried about their ability to work for their job than those of matched controls. So in this, we break it down by responsibility, their flexibility to change job, to move places, to get up and try something different, their skill acquisition, their ability to communicate, their ability to their self-view of themselves. And you see the largest significant change is from health safety purposes, because individuals with neurofibromatosis have tumors and have different presentations. There is a reason for individuals to be more conscious or mindful of their health safety. However, when we look at their hope, it's pretty much the same as the matched control, in the sense that the ability to look at all of these different factors, they're pretty much well in line, saying that we believe both from an individual who has neurofibromatosis to that of a matched control, we believe that in our hope that to ourselves that we can there is no difference between us, but there is a significant difference within their anxiety and their depression. And so I think you need to be mindful, once again, about how we go about our daily life with pain, and how our pain can affect not just one variable, but our entire daily routine. So I want to make sure that I have time to answer any question. So I'm going to briefly go through some conclusions, and I think we've talked about it pretty intensely, that pain severity and interference are very prevalent within NF. We have some preliminary information within NF2, which I skipped over, and I apologize. I can more than well be willing to share with anyone with NF2, saying that the individuals with chronic pain with NF2 are just as, or if not more, impacted by chronic pain than as NF1. These physical pain symptoms affect the entire body. Excuse me. And then there are, as I said, both a psychological, a medical, and a social perspective that need to be encapsulated or understood from both a clinician perspective, a individual with the disease, and the community at large. And so we need to talk more about pain, more understanding about the pain and how this affects ourselves. I'll skip these conclusions because I think I've discussed a little bit about this, but I want to briefly just talk about, I have currently a CDMRP DoD funded mobile application to help reduce chronic pain, and we are about to go into a clinical trial starting in March of 2021. And anyone who's interested in participating in this mobile app exercise, we would always be willing to take individuals into this study. And we can talk more about this in detail. And I can refer you to my research assistant, and she can tell you a lot more than I can with my short period of time. I do want to thank the Congressionally Directed Medical Research Program for supporting my research. And I also want to thank my research collaborators, Loretta, Sam, Asher, Dr. Bob, my research assistant, Caitlin, and my collaborator at Lock Haven University, Matt Sprung. If you guys have any questions, that's my direct email. Please take it down. Feel free to send me an email at any time. I rarely sleep, as my wife could probably contest to. I probably get, go to bed around 2 and get up at 6. So, if you have questions, I'll try to get back to you as quickly as I can. And then within the subject line, please say, you are a patient, so that I can get to your comment quicker. With that, I want to thank you guys once again so much for giving me the opportunity to talk. And I'm opening up for any questions or any time. So I think that's what I have for the talk for today.
Perfect. Thank you so much, Dr. Buono, for presenting on this topic. It looks like we do have a few questions in our Q&A box. Would you like me to read the questions, or would you like to take a look at them yourself?
Let's see if I can do this. Okay, so I think I can pull these up. Lynn is asking me a question about, is there any way pain affects NF2 the same as Schwannomatosis? And so I think if I'm hearing you correctly, or if I'm reading this correctly, Lynn, and you can correct me if I'm wrong in the box, pain affects NF2 differently than Schwannomatosis. And the issue with Schwannomatosis is that there's a lot of missing research within Schwannomatosis because of the rarity of the disease. And so from a research perspective, if we're going to get a lot of individuals, because the current prevalence, as you probably know, is about 1 in 40,000, 1 in 45,000, it's very hard to find a lot of individuals with pain. I know Dr. Merker at NIH and is doing some preliminary work on Schwannomatosis, but my guess is, in answering you just overall, it's going to be different. How so? I can't really completely define that for you. I think John's got a great question here. For pain management, is opioids better or cannabinoids for long-term treatment? John, this is a conversation which is going along currently in the pain community, and the answer is I don't know. And the problem is there's not enough information as we speak right now. There are individuals who will say cannabis is got a better effect over long term than opioids, but the current empirical evidence is that there isn't a clear definition. I would talk to your doctor about this. And in certain states, I know that medical marijuana for neurofibromatosis has been approved. It's one of the first diseases to get medical marijuana, and so you might want to talk to your doctor about that. But I'd be very mindful about, because cannabis is a drug, the addictive qualities of it, depending on where you get it. And so with Bill's question, I have schwannomatosis. My first tumor was removed in 1978. I was treated 2 years ago with oxytocin and a high dose of fentanyl patches. Never better. The pain. How do you feel about opioids for NF treatment? It's Bill. You have a really great question. It's a phenomenal question. I think opioids. Here's my short answer for it, and I can probably talk about another hour and a half about opioids, but for the short-term effect of medication for opioids, I think they do wonderful jobs. I think it's when you're talking about the long-term effect is what becomes problematic, and I don't mean long-term like 6 months. I'm talking a year or more, and I think that what opioids were specifically targeted to do was for short-term post-surgical procedures, and it wasn't ever meant to be prescribed for a long duration. So I think you just got to be mindful about the dosages and talk to your doctors consistently. Great. So Elisa is talking about abdominal migraines and how do I convince my daughter's doctors about the stomach pain if it's not really a typical GI issue? That's a great question. And so what I think you need to think about, Elisa, is when it goes back to pain, it's not talking just about the severity of pain. It's not just talking about the interference. It's also about tolerance and the ability to deal with the pain. So I think that you need to have a conversation with your doctor, or at least I would recommend, talking about the different factors of pain with them. And I'm more than willing to, share my slides so that you can, go in to your next doctor's visit or doctor's call, whether it be Skype or in person or whatnot, to clearly inform them, because you need to advocate for your daughter, you need to advocate for yourself, if you have the disease, about how this pain is affecting. My guess is if it's affecting your daughter enough so that you're bringing the question up to me, that I would bring it to your physician or your care team and talk to them about that. Hopefully that answers your question. Sharon, yeah, I'd love to talk about the mobile app. I can definitely provide it. So what we're doing with the mobile app is the mobile app is designed to provide ways for individuals with neurofibromatosis to self-manage their pain through different types of complementary and alternative procedures and so that they can look at their pain. So what we're going to be doing is we're going to be you can be able to see your pain, you can be able to take your pain and graph it out and show your doctors, well, today I had pain at a 7, yesterday I had a pain at 3, so something I did today, and what that's going to do for your doctor relationship is going to be very important. And then we can also interchange that with anxiety scores and depression scores and other evaluations. I can talk to you about all the positive qualities of my mobile app in a longer conversation, but just for time's sake, I think there would be a lot of asset for individuals with neurofibromatosis. Carmen, I'm going to try to see if I can answer your question really quickly. I have NF1 and there's no group support, and I have severe pain, and I'm taking gabapentin. You're taking 10 pills, doesn't help. And Carmen, I can tell you that you're not alone with that example. I have patients who I see clinically who are on the same dosage, if not higher than you are, and there is no social support. I would recommend highly to get involved with NF Central Plains Advocacy, NF Network. They have a lot of different social support mediums, and they can talk to you about it. I think, moving forward, This is just on top of my head. If we want to do a routine call in, talk about pain, I'm more than willing to, spend an hour, every month, talk to you guys about pain and just see how you guys are checking in, and we can talk from there. I know I'm a little bit over. There's some chat questions. I will definitely share my slides. I will give them to Brianna or Sharon, and you guys can take from there. If you guys do have any other questions, something pops up, and I just got a couple emails already, which is awesome. Thank you for that. I will try to get to these as quickly as I can, and have a great rest of the day. I hope you guys enjoy the rest of the conference, and talk to you guys soon. Take care.
Perfect. Thank you so much, Frank, for putting on this presentation today. We truly appreciate your insight on this. At this time, we're going to take a second to get ready for our 1 o'clock presentation with Dr. Uche Eleja. He will give a presentation on clinical trials from a pharmaceuticals perspective. So thank you, everyone, and we will see you again soon.
Bye-bye.